Good morning, everyone. I think we'd better get started. We've got an exciting morning ahead. I'm Stephen Litton. I've been a GP partner in my practice for 30 years in a deprived area, so plenty of experiences of the challenges of respiratory disease. As GP lead, I'm very keen to be contacted about issues and problems you're having, and I'm co-hosting with Sarah Crouch, who's been key to developing much of the respiratory services that we've got. I'm thrilled that so many clinicians have managed to join us this morning for what I'm sure is going to be a very interesting and informative time. Respiratory medicine has, of course, been at the front line of the COVID pandemic, and so I'm extremely grateful to the experts who have so kindly managed to do presentations for us today while still overwhelmed by clinical workload and planning for the future, something that we, of course, all share with them. We really hope that you're going to feel supported and enthused, as well as learning something which is going to improve your patient care from the presentations today. There are unfortunately still questions and concerns that we do not have all the answers to, particularly spirometry, but we're working to find those solutions, and we will give time to talk about this at the end during the panel discussion. Housekeeping, I'm sure you know where the exits are and the toilet, and we're going to endeavour to take some breaks to allow you to grab refreshments. The event is being recorded in case you're called away or are unable to stay for the whole morning. As you know, we're asking you to keep your microphones and cameras switched off unless you're talking. We're going to be monitoring the online chat, and at the end, as you'll notice, we've given half an hour for a panel discussion for those questions, although if there are any burning questions and times at the end of any of the talks, we will answer those questions at that time. For those who are listening to this as a recording and have feedback or questions, please feel free to email me, and I'll try to respond to all your queries, possibly in a newsletter. Finally, I'd like to thank the team who've organised this, Sarah Crouch, Gemma Meesaw and Tracy Strudwick from East Sussex County Council, who are of course now all part of the ICS with us. I'll now, without further ado, transfer you to Teresa Christopherson, who's the respiratory consultant at the Conquest, who's going to talk about the challenges of managing asthma. Thank you very much.
Good morning, everyone. My name's Teresa Christopherson. I'm a chest consultant at Conquest Hospital. And I'm going to discuss today the challenges of managing asthma in 2021. So we're going, by the end of this presentation, you'll know the definition, the risk factors and the epidemiology of asthma in 2021, the immunology and phenotyping that we use, and how to evaluate asthma effectively in your practice. We'll discuss the guidelines for step treatment for mild, moderate and severe asthma, and then we'll talk about some specific phenotypes that cause challenges to physicians. So asthma, the Greek name for asthma it means panting, and it's a heterogeneous disease. It's caused by chronic airway inflammation, and the symptoms vary over time and with intensity. It's characterized by a variable expiratory airflow limitation. It's the most prevalent chronic respiratory disease worldwide, and it's increasing. In childhood, boys are more affected, but in adulthood, women are more affected. And it's caused by many different things. It's a combination of genetic factors and environmental factors. And we know that certain things are protective. For example, a child who's born by vaginal birth, who has many siblings, and microbial diversity in childhood has more protective factors. However, things that contribute to asthma are air pollution, smoking, obesity, diet, and particularly viral illnesses in early childhood. It is known to be inherited. It's up to 35 to 70% inherited factors. So the pathophysiology is related to airway hyperresponsiveness, smooth muscle hypertrophy. I'll move on to where we got to then. So we were talking about the pathophysiology of asthma. So it's characterized by airway hyperresponsiveness, smooth muscle hypertrophy, airway remodeling, and mucus hypersecretion. And there are two main pathophysiological causes of asthma. There's type 2 or immune asthma. And in type 2 asthma, allergens, pollutants, and microbes stimulate inflammatory cytokines such as IL-33 to activate the T helper cells to develop a cascade of cytokines, namely IL-13, IL-6, which develop a mast cell response, an IgE response. And this contributes then to smooth muscle contraction. The innate response is also stimulated by pollutants, microbes, and other factors which stimulate cytokines, which again lead to eosinophilic. And we're talking about phenotypes of asthma. So it's an observable characteristic which results from a hereditary or environmental influence. And the endotype is the mechanistic molecular pathway that is created by the situation. And the biomarkers are what we use to measure the disease severity. So overall, asthma is an umbrella term which encompasses the environmental and the genetic factors that contribute to the phenotypes, and there are a number of different endotypes that cause it. The biomarkers that we use are multiple now, and in general practice we can use IgE for the immune modulated type 2 asthma. However, it isn't specific, and we shouldn't rely on it completely. We can use blood eosinophilia to look for allergic asthma, and in research settings we use sputum eosinophilia. In clinical practice here in the hospital we can do FeNO to measure those types of asthma which are driven by IL-13. So we're going to now talk about how to evaluate asthma objectively in the practice. Well, unfortunately, asthma isn't always what it seems, and in fact some studies have shown that up to 30% of adults with asthma actually don't have asthma. So it's really important when you're evaluating a patient to think maybe they don't have that, maybe it's an alternative diagnosis. And in the very young age groups, things to look out for are other conditions such as bronchiectasis and hyperreactive upper airways. In adults over the age of 40, it's really important to think about COPD, particularly if they're smoking, and other illnesses which may be contributing, such as heart failure and central airway obstruction caused by lung cancers. So the things to look at are, first of all, the symptoms. Often patients present with wheeze, breathlessness, and cough. However, if it's very severe asthma and you listen to their chest, they may not actually have a wheeze because the airflow is so tight. Their symptoms vary over time, and typically they're worse at night or in the early morning, and they may have an identifiable trigger that they say causes symptoms. It's really important to talk about whether they had asthma in childhood and if they have a family history of asthma or atopy, because that contributes a lot to the underlying diagnosis. And then talk about their occupation, think about what might be triggering it in the community. Examination really is to check for nasal polyps, any rhinitis that may be contributing, and obviously clinical examination to look for any other signs of asthma. In clinical practice, we need to objectively measure variable airflow obstruction and an improvement with a bronchodilator to confirm asthma. And in clinical practice, we look for a diurnal variation in the FEV1 of up to 10% of the peak flow. And in between visits, we expect the FEV1 to vary. It should improve by 200 mils or 12% with a bronchodilator. And overall, the FEV1 of FVC ratio should be less than 80% to confirm asthma or airflow obstruction. So I'm now going to go through the guidelines for asthma management. So the goals of asthma treatment are to improve symptom control, reduce comorbidities that may be contributing, and improve the lung function. And we want to reduce the exacerbation rates, the use of medications, particularly oral corticosteroids, that have so many adverse side effects. And so now asthma control is now divided up into factors that contribute to the severity. And these are the GINA guidelines that we all follow. They were most updated in last year in 2020, and you can see they're based on a stepwise progression of the patient's symptoms. The new changes to the guidelines are that you can use a combination inhaler of an LABA ICS much earlier on as required, and that's a change to the guidelines, which is now contributing to better asthma management. You can see that once the patient reaches the threshold of step 4 and step 5, they're on oral corticosteroids a lot of the time, and despite inhaled high-dose corticosteroids, they still have symptoms. And these are the patients we want to refer on for biological therapy, which I'll be coming to at the end of my talk. So the key to asthma management is to assess the symptoms, the exacerbations, what's contributing to it, the lung function and the patient satisfaction with their treatment, and then adjust their treatment according to the modifiable risk factors, the pharmacological strategies and asthma medications, and then review to confirm you've got the right diagnosis, the correct inhaler technique, and to treat any underlying comorbidities, which I'll be coming to at the end of my talk. So inhaled corticosteroids for asthma are a significant treatment which really does improve their control. It reduces the risk of future exacerbations and it reduces mortality. Particularly, it improves lung function and it can eventually prevent airway remodeling, which is the most important thing for long-term improvement. And nowadays, we recommend ICS or inhaled corticosteroid with a long-acting beta-2 agonist. And the combination improves both the symptoms, lung function, risk of exacerbations, and it does reduce the amount of relievers that they need during the day, or short-acting relievers. An addition of a LABA to a low-dose inhaled corticosteroid is much more effective than just increasing the inhaled corticosteroid on its own. And that's why the GINA guidelines have changed to say at an earlier stage, you can use a combination inhaler PRN. And it's really important to remember that long-acting beta-2 agonists should never be used on their own as monotherapy in asthma, as they contribute to tachycardias and ventricular arrhythmias. Long-acting muscarinic antagonists now are also used in asthma. The one that's recommended is a soft mist inhaler known as Respimab 125, and it's the only one currently licensed for asthma. You can use it as an add-on with an inhaled corticosteroid to improve lung function, and with the long-acting beta-2 agonist, it can also improve asthma control and reduce the time to exacerbation. It should be noted that you shouldn't use a long-acting muscarinic antagonist such as tiotropium on its own as monotherapy. It's meant to be used as an add-on to inhaled corticosteroid and a long-acting beta-2 agonist. Now, leukotriene antagonists are also used in asthma. They can be used as a monotherapy early on in asthma for mild asthma to reduce exacerbations. They improve quality of life, but their effects are variable and they're less effective than inhaled corticosteroid. They can be used particularly for those patients who have exercise-induced bronchospasm or those who have a sensitivity to asthma. Sorry, aspirin, I meant. So as you can see, all of these treatments come into play when you're using treatments to control asthma. I'm now going to talk a little bit about severe asthma because that's what we're seeing in clinical practice at this time. Severe asthma is defined as asthma that requires step 4 or step 5 treatment according to the GINA guidelines, or oral corticosteroid for more than 50% of the preceding year to prevent poor control. It also is defined as severe asthma when the patient requires inhaled corticosteroids at high dose or systemic corticosteroids or additional biologics for a sustained period of time. And the things that contribute to severe asthma are multiple. Acute rhinitis and chronic rhinitis are seen in a large proportion of patients with severe asthma. We also see those patients suffer with reflux, and a very large proportion of them have obstructive sleep apnea, which, unless you treat, contributes to persistent hypoxia at night, which generates bronchoconstriction and very poor asthma control. Vocal cord dysfunction, anxiety, and depression are also very prevalent. As I said, reflux is seen in asthma. Up to 30 to 80% of patients have it, but not all are symptomatic. Those that are symptomatic, we really should treat because it does improve their control. Rhinitis, again, is often seen in 84% of patients with severe asthma, and it contributes to very poor quality of life and poor sleep.
All right.
Vocal cord dysfunction is also very common in patients with severe asthma, and it can mimic asthma as well. It's seen both within the condition and as a mimicker. And it's hard to diagnose it. The things that should trigger your thoughts of a severe asthma patient having vocal cord dysfunction are those with rapid onset of symptoms that seems to have a trigger that causes it. The only way really to confirm it is laryngoscopy with the ENT team, and the treatment involves speech and language therapy. So now I'm going to talk a little bit about the biologics that we use in asthma, and this is the new form of treatments that we're all talking about for those in step 4 or step 5. And these agents are multiple. Omalizumab is used for asthma caused by high IgE levels. It's given subcutaneously, and it can be very effective for allergic asthma. There are 3 agents that contribute to asthma care who act on the IL-5 mechanism. And then dolizumab works on the IL-4 mechanism and is particularly helpful for those with skin changes and dermatological treatments. So we're going to go through each of these now. Anti-IgE or monotherapy is known as omalizumab, and it's a recombinant monoclonal antibody. It binds to the circulating IgE, and it has a high affinity to the IgE receptor. It's indicated in moderate to severe asthma when the IgE levels are elevated and there's a skin sensitivity to at least one allergen. Unfortunately, it does come along with problems. Up to 0.2% of patients have delayed anaphylactic reactions, and that's why a lot of our patients are advised to carry EpiPens with them if they're on this type of medication. Anti-IL-5 treatments there's 3 of them: omalizumab, reslizumab, and berimab. It's indicated in severe asthma as an add-on therapy, and it's given either subcutaneously or IV. IL-4 treatments is dupilumab, and this was really recognized in the last couple of years. It acts by binding to the IL-4 receptor, and it inhibits the activity of IL-4 and IL-13. It's indicated in moderate to severe eosinophilic asthma and those who have steroid-dependent asthma. It's required at high dose, and it particularly helps those patients who have atopic dermatitis. See, the efficiencies are very good, as you can see in the slide. All of the treatments reduce the exacerbation rate by about 50%, and the amount of oral corticosteroid dose is also reduced by up to 50%. Now, all of those treatments we've just been talking about work for allergic asthma or type 2 inflammation. And unfortunately, as I was saying earlier, up to 50% of asthmatics don't have an underlying immune or type 2 inflammation causing their symptoms. And treatment for these patients is very difficult and challenging. And unfortunately, there are limited treatments available. However, the things we can think about for these patients are macrolide antibiotics and potentially referring them for bronchial thermoplasty. Now, azithromycin was recognized in the AMAZE trial in 2017. It was the largest randomized controlled trial for azithromycin and asthma, and it involved 420 patients. Those patients were symptomatic despite high dose inhaled corticosteroids and a long-acting beta-2 agonist. And it was given at 500 milligrams 3 times a week over 48 weeks, and they found a significant improvement in exacerbation rates. Bronchial thermoplasty is also used for these patients who have non-allergic or type 2 asthma, and it acts on the cause, which is an increase in smooth muscle contractility. It reduces that, and as a result reduces hyperresponsiveness within the airway. And the trial that showed that it was effective is called the AIR2 trial. So we've talked a little bit about the STEP guidelines for severe asthma, and now we're going to talk a little bit about the phenotypes of asthma, and then I'm going to go through some questions to see what you all feel might be the appropriate treatments for these challenging patients. So one of the phenotypes that we see in clinical practice is aspirin exacerbated respiratory disease. And these patients often present with chronic rhinosinusitis and nasal polyps, and then bronchospasm, which develops particularly after having aspirin. It's a non-IgE mediated form, and it's seen in about 7% of adults with asthma. It can take many years to develop severe asthma, and it can be associated also with angioedema and GI side effects. So the treatment really is as for asthma, but be aware that aspirin might be contributing. Early uses for leukotriene antagonists can be very effective, and avoidance of all non-steroidal anti-inflammatories. There is a form of therapy known as desensitization, which can be very effective for these patients. Another phenotype that we see in clinical practice is exercise-induced bronchoconstriction. And these patients develop bronchoconstriction normally 10 to 15 minutes after exercise in cold air. And the diagnosis is made by seeing a 15% drop in the FEV1 after exercise. The treatment really involves using a short-acting beta agonist before exercise, and then adding in inhaled corticosteroid and long-acting beta-2 agonist to their general treatment, along with leukotriene antagonists. Now, as we've all probably seen in practice, a lot of our patients are becoming more overweight, and this is a particular phenotype of asthma now. Unfortunately, obesity contributes to very poor asthma control and increased healthcare utilization. And it contributes in many ways. As I said before, sleep apnea contributes to hypoxia at night, which generates bronchoconstriction, but also increased adipose tissue is an inflammatory state, which contributes to the underlying immune form of asthma. The treatment is really weight loss, both dietary and surgical, and obviously exercise is very beneficial as well. Occupational asthma is a very important thing to look out for. It's particularly seen in those patients who work in settings where they're continuously exposed to allergens. It's always important to think of it in the history if the asthma typically gets better during holidays and weekends away from work. And there are many different forms of occupational asthma. The forms caused by high molecular weight allergens are those professions such as bakers and cooks who are exposed to flour. Those working in pet shops may develop allergens to the pets there. Healthcare workers can develop allergies to latex, and obviously nurses dealing with large quantities of antibiotics can develop this form of asthma. Low molecular weight allergens are those seen in plastics. Dentists often develop this to the chromoglycates they use in their practice. And the symptoms particularly are of rhinitis, wheeze, ocular and skin itching, particularly when those patients are at work. You can make the diagnosis from skin tests and serology, measuring their peak flow when they're at work and away from work. And then particularly in the hospital setting, we can do an inhalational challenge. The treatment, unfortunately for those who have sensitized induced occupational asthma, is to avoid it. But those who do not have that form need to reduce their exposure as much as possible, use PPE, and optimize their asthma control. So in the last few minutes of my presentation, I'm going to go through 3 interesting, challenging cases that we probably all see in clinical practice, and we can talk about what might be the best appropriate therapy in 2021. The first patient is a 30-year-old gentleman who's had a 6-month history of episodic shortness of breath, cough, wheeze, and it all started after a lower respiratory tract infection about 6 months ago. He now develops symptoms of breathlessness when he exercises in the cold air, and he wakes up from sleep at least once a week due to wheeze and breathlessness. He does have a history of childhood asthma, but he was asymptomatic from his teens, so he stopped using his inhalers. And on examination, you find he has scattered wheeze throughout both lung fields, normal observations, and an FEV1 of only 75% predicted, with an improvement with 15% with inhaled salbutamol. His chest X-ray is normal. So thinking about what the best appropriate treatment would be, perhaps you could put in the chat what you think the answer may be here. Should we treat him with a short-acting beta agonist as needed, or perhaps a long-acting beta-2 agonist with an inhaled corticosteroid as required? That's answer B. Answer C would be long-acting beta-2 agonist with inhaled corticosteroid twice a day. And then finally, a daily leukotriene receptor antagonist and a short-acting beta agonist as required. Would everyone like to put their answers in the chat? See if I can see that. Would the person chairing the meeting be able? Oh, I can see your answers. Fantastic. So I can see quite a range of answers, and you're all getting the correct answer, more or less. It's C. So according to GINA guidelines, here we'll be recommending a scheduled inhaled corticosteroid with a long-acting beta-2 agonist at least twice a day. You can add it in as required as well, but it's best to step up. With the GINA guidelines, you don't have to start off at the lowest level. This patient's getting symptoms at least once a night. It's affecting his quality of life and activities of daily living. So in this situation, I would always start at a higher step, and the highest step we'd recommend here is the LABA ICS scheduled dose, and then he can take it also as required as well. So the correct answer there was C. Well done. So as you can see, the step guidelines are here, and we would recommend starting at a higher step, and then you can always go back later. Okay, well, the second case is a 55-year-old lady who has uncontrolled symptoms of asthma. She was diagnosed at the age of 33 with asthma by having an inhalational challenge in a hospital. And now she's 55 and she's reporting daily symptoms. She hasn't attended A&E or needed oral corticosteroids, but she is saying she's using her inhaled corticosteroid and long-acting beta agonist every day as she's been prescribed, and she's using her short-acting beta agonist as required, which unfortunately is becoming more and more persistent. She's got a history of reflux, and when you examine her, you see her BMI is 45. You've done some blood tests, and her IgE and eosinophil count are normal, and her skin prick tests are normal. So what treatments shall we recommend for this patient? Should we A, add in a theophylline, B, add in oral corticosteroids, C, add a trial of omalizumab, D, perhaps do an Epworth score and consider sending her to Dr. Merritt for sleep studies and a CPAP trial if we confirm sleep apnea, or E, should we consider weight loss? And there are two treatments here we'd like you to consider. So I can see some members of the audience are replying, oh, fantastic. So you've all got the correct answer, which is refer for sleep studies and encourage her for weight loss. That's exactly the right treatment we should recommend. And there's lots of evidence for this now. So there have been many studies since 2013, 2008 and 2007, which showed that an intervention such as weight loss of up to, well, typically it's between 7 and 10%, significantly improves both asthma control, symptoms and lung function. So when you talk to your patients about weight loss, there is a lot of research out there that shows that if they lose up to 10% of their weight, their asthma control will improve. And this isn't just through dietary mechanisms. This study showed that surgical weight loss can actually contribute to improved asthma control as well. Okay, so I'm just coming up to the last few minutes of my presentation, and I've got a final case I'd like to discuss with you. So this is a 45-year-old asthmatic gentleman. He's been symptomatic since childhood, and he presents with frequent symptoms despite an inhaled corticosteroid at high dose and long-acting beta agonist. And he's been prescribed 10 milligrams of prednisolone a day, and he still has symptoms. He's required 2 hospital admissions in the last 12 months for severe asthma, and he has atopic dermatitis, which is poorly controlled despite the topical agents that have been prescribed. His spirometry shows moderate airflow obstruction with bronchodilator reversibility, and his blood tests show that his IgE level is low, his skin tests are negative, but his eosinophil count in his blood is quite high. So he's obviously at step 4 to 5, he's on corticosteroid, both orally and inhaled. And if we were going to think about referring him for biological therapies or alternative therapies, what does everyone think? Should it be A, olanzapine, B, delimizumab, C, rozumab, or D, bronchial thermoplasty? Oh, fantastic. All your answers are coming through, and you're absolutely correct. It should be B, delimizumab. And the reason for this is because he's got eosinophilic oral corticosteroid dependent asthma and atopic dermatitis. And the studies show that this type of therapy is particularly effective. It's important always to think about why the others aren't quite such a good option. And the reason for that is olanzapine is better for IgE mediated asthma. Rozumab isn't really studied in those who require oral corticosteroid long term, and bronchial thermoplasty, as I said earlier, is for non-allergic or non-type 2 asthma. So this slide just talks about delimizumab, and it shows that it's an IL-4 receptor antibody. It's particularly effective for those who have moderate to severe dermatitis, and it improves oral corticosteroid use, asthma control, and lung function, and reduces exacerbations. And you can see all of the biological therapies reduce the oral corticosteroid use by up to 50%. So I've reached the end of my presentation. Thank you all for your attention. And I think we're going to do questions in the panel, aren't we now, or move on to
that's right.
The other presentations.
Thank you very, very much, Teresa. That was absolutely fantastic. Really gave, I'm sure, all of us some new understanding about the concepts and guidelines for asthma, and both holistic care and as well as the most up-to-date monoclonal antibody therapy. Can I now introduce Dr. Geeta Gopal, who's a consultant paediatrician in Eastbourne, specialising in specialities including asthma and respiratory care of children. Dr. Gopal, do take over control.
Thank you, Steve. Thank you for asking me to talk. So I've been a consultant at Eastbourne for about 20 years now. So some of you may know me, and I do work cross-site. My talk is going to be very basic. I'm not going to go through to tell you how to manage asthma, but more the challenges in children with regards to asthma. Can I move the slide, or is somebody's going to move it for me? I'm not okay. So I'll start by saying that we all know that this is the latest report, that it's a very common lung condition, and it does affect 1 in 11 children in the UK. And this is as per the Asthma UK data in 2021. Thank you. Next slide, please. So I'm just going back because I think the biggest challenge in childhood asthma is making a diagnosis. And I have kind of picked up some slides and some data from the recent HSIB report, where there was an investigation into a near fatal case of asthma in a child, where the challenge had been because nobody had made, or the communication of the child having asthma had not been communicated between the primary and secondary care. And we do know that the younger the child is, often there is a difficulty in making a diagnosis of asthma. And hence the treatments offered both in primary and secondary care can be varied, and which often leads them to come in with quite severe exacerbations. So very briefly, it's a very long-term respiratory disease, which is associated with airway inflammation and hyperresponsiveness. So I think the challenges of treating is to address both these aspects. One, the hyperresponsiveness and the airway inflammation. Next slide, please. So again, as far as pediatrics is concerned, even though I think the current climate is suggesting that we should be using supportive tests to make a diagnosis of asthma, as far as pediatric is concerned, I still believe it is a clinical diagnosis because the tests are more challenging to do in children. Often it's difficult to interpret them. So I think we have to keep it as a clinical diagnosis for the moment, which is a whistling sound made during breathing. There can be chest tightness, breathlessness, and sometimes excessive cough production. So the management is based on the identification of the treatable traits in each patient. Thank you. Next slide, please. So in preschool children, it's often an episodic disease, so you don't often have any symptoms in between. And so they're completely near normal between the periods of exacerbation. And where you can do lung functions, you'll see that in between these periods, these lung functions can actually be quite normal. And then periodically, they have these asthma exacerbations. So I think what they are kind of suggesting that if you do see a child with a wheeze, with recurring episodes where you have repetitive episodes of wheeze, then it's okay to make a documentation of a suspected asthma, because in the preschool age, this describes a potential diagnosis of asthma based on symptoms and response to treatment that has not yet been confirmed with objective tests. I think this is very important, because then at least there is kind of communication between the primary and secondary care, and the understanding of the parents that there is a potential asthma is also beneficial for them to continue with the treatments that have been prescribed. Thank you. Next slide, please. So again, I'm focusing and emphasizing more on the diagnosis, because I think this is the main issue with children, especially the more younger they are. So while labeling a child as asthmatic may not reduce morbidity, but assigning a diagnosis does lead to improved care. So this is in relation to attention being given to the inhaler technique, a proactive follow-up by the nurse or doctor, and the development of self-management skills and better explanation to. So I just picked up a couple of points. So again, I mentioned about the Healthcare Safety Investigation Branch, which was a big investigation, which the report came out in May 21. So just briefly talking about this child, or the summary of the investigations. There was this child was an ex-preterm who I think had been recurrently coming into primary care and secondary care. Of course, he had other comorbidities, and every time he presented with a wheezy episode. Because he was young, a label of suspected asthma was not given, and the mom had not been conveyed this information that this could be asthma. And again, there had been some delays in the follow-up in the secondary care as well. So she was not compliant with the medication because she didn't understand this was asthma, and B, she wasn't able to use the short-acting bronchodilator effectively during periods of wheeze because she hadn't been told that this was asthma and this is how the management should be. So as a result, the child did end up with a near fatal exacerbation when eventually the management was then confirmed. The diagnosis was then confirmed, and then there was referred for this investigation. So there were a lot of recommendations, but I have just picked up a couple, again, based or kind of alluding to the diagnosis. So what their safety observations was that it may be beneficial if suspected or possible asthma diagnosis is communicated both ways by secondary care to children, families, and other care sectors, where asthma is being considered as a diagnosis but not formally diagnosed. And also it is beneficial if these children were coded as having suspected asthma, especially if they're under 5 years of age, because again, it does have an impact on the management and the use of self-care plans. Next slide, please. So I think the key factors, in pediatric setup is considering a diagnosis of asthma or suspected asthma. And I'm not going to go through the stepwise management because I think it's all there and I'm sure everyone is aware of that. But it is about initiating an appropriate management plan, both in the acute and chronic setting. So you all would have seen children presenting with acute episodes and obviously with chronic symptoms in the primary care. Important to use the appropriate inhaler device, and for children, it is the use of spacers. There are quite a lot of parents who come back to the clinics not using the spacers because they feel the children are fighting it or not using it appropriately. But I think that's the most important thing. And this again goes back to frequent education on how to use and ensuring that they're using their devices properly. Again, avoiding routine use of antibiotics. And I think this happens because when they come in, they do have a wet cough sometimes. They often have a little bit of crackles, which is probably more due to inflammation rather than a bronchospasm, and often are treated with antibiotics rather than anti-inflammatory agents, which is probably what is needed. And I think education and written management plans, I think, is the emphasis of asthma treatment. Even though there are a group of patients who have difficult asthma and may need stepping up of the treatment, but in pediatric age group, thankfully, this is very, very small as compared to the adult population. And I think everything comes down to parents being educated on the appropriate management during acute episodes and to be able to seek medical help when needed. And I think monitoring control and adherence is again an important thing. I think adherence has to be a factor or a question that is asked every time they come in with an exacerbation, because that often is a big issue when there is poor control. And I think last one is the appropriate referral to secondary care. I think following this HSIB investigation and the National Review of Asthma Deaths, I think there had been some few criteria when they felt that the primary care should be referring on to a secondary care. And I will talk about that in one of the later slides. Next slide, please. So this is just something that this is taken from one of the, this was a document from one of the primary care trusts in the kind of Milton Keynes area. So what they have suggesting is that if you see a child under 5 presenting with symptoms of asthma, which consists mainly of wheeze, cough, breathlessness, and chest tightness, I think they are suggesting a structured clinical assessment to specifically check for wheeze, cough, or breathlessness, and any daily or seasonal variation in these symptoms. Check about any triggers that make these symptoms worse, and a personal or family history of atopy. To look for recurrent episodes of symptoms or absence of symptoms of alternative diagnosis, which again is important in children, and recorded observations of wheeze. More and more people are saying that you should have heard a wheeze during an acute setup to be able to think of a diagnosis of asthma. So really to examine the child to identify expiratory polyphonic wheeze and signs of other causes of respiratory symptoms. So obviously, if you're seeing them in between an episode, you may not hear a wheeze, but I think it is important that when they come in, that there are some signs of wheeze. So what they're saying is when you see that, do treat symptoms based on observation and clinical judgment, but review the child on a regular basis. You could either opt for a watchful wait, but if they're having recurrent episodes, then you have to initiate treatment. And they're not suggesting offering a routine diagnostic tests like skin prick tests to aeroallergens or serum IgE in children when they present to the primary care setup. Next slide, please. So what they're saying is after clinical assessment, treat episodes of wheeze according to the most severe feature. I think reassurance and advise parents and carers with written information or discharge plans. And I think if you are doubtful or not sure, then you can use the code of suspected asthma and advise parents and carers with supplementary written information. And I think this is perhaps the most important thing, even with the first episode of wheeze. Even though you don't think it's asthma, you can kind of write it as either viral wheeze, but everybody should have some kind of a management plan, or the parent should be told how to use the bronchodilators or the short-acting bronchodilators and when to seek medical advice. Next slide, please. Again, for older children between 5 to 16 who have a diagnosis of asthma, or you've made a clinical diagnosis of asthma, I think including an advice in their self-management plan on contacting a healthcare professional for review of their asthma control deteriorates. And this is again something that even though, and this I see in the secondary care as well, even though parents have been told to seek advice appropriately if they are needing their Ventolin more frequently than 4 hourly, I have seen loads of parents using the Ventolin hourly at home and then coming in when they're really, really bad. So I think this again boils down to education. It seems to be people don't seem to think, and even parents sometimes don't think that asthma is a serious condition, and they want to try and do everything to try and avoid coming into hospital, because often these children come in and we do discharge them the next day, because all we do in the hospital is perhaps deliver the bronchodilators more effectively and give them a short course of steroids. So parents think that they can tide with the situations, but this is when they come in quite an extreme state. So next slide, please. So there are certain supportive things, as I said, when you're trying to make a diagnosis of asthma. So age at presentation, the natural history of the wheeze is dependent on the age. So the younger the age, the better the prognosis, because often these are triggered by infections. And as they get older, if the viral infections reduce, then their wheeze will improve. Severity and frequency of previous wheezing episodes. So frequent or severe episodes of wheezing in childhood are associated with the recurrent wheeze that can persist into adolescence. I think, as Teresa has said, coexistence of atopic disease, such as eczema and rhinitis, increases the probability. So again, these are factors that you can consider when you see a child presenting with a wheeze. A family history of atopy is perhaps quite a clearly defined risk factor for atopy and asthma in children. But again, one of the things that we all forget, and even in my clinic sometimes we forget to do it, is to be advised of the many adverse effects of smoking, which has on the children, including increasing wheezing in infancy and increased risk of persistent asthma. And you would probably see the number of times that parents often say that we smoke, but outside the house, and we have a different jacket that we wear when we smoke, and we change them. But I think there have been studies that have shown that even parents who don't smoke in front of their children, who end up with difficult asthma, when we've checked the urinary creatinine, that has shown evidence of nicotine. So I think that shows that even though they're not passive smoking, they're not smoking in front of their children, this has a big effect. So I think sometimes simply supporting them to stop smoking can improve the children's symptoms. Next slide, please. So I don't know whether you can see that properly, but it's just a kind of a structured thing of clinical assessment and when we think that other tests will be needed. So if there is a recurrent episode of symptoms or symptom variability, and you are fairly sure there's no absence of symptoms to suggest an alternative diagnosis, then I think what they're saying is to try and code it as suspected asthma, initiate treatment, and you kind of assess the response objectively. So if lung functions, as I said, is not available readily, you can kind of do a asthma control test, which can help you to make a diagnosis whether symptoms have improved. And if there's a good response, then you can continue to follow them, adjust maintenance dose, and provide self-management care. But if the poor response, and if you're not sure, then I think is when we suggest that you refer them in to perhaps consider the alternative tests. Again, children under 5, this is very difficult, and even children 5 and over, this is very difficult to do these tests, but at least we can make an attempt to do them and perhaps try and make a diagnosis of asthma. But if all these tests are negative, then again, I think we probably have to kind of treat as a probability of asthma and continue the management. And things where you feel that you have initiated treatment, there is no response, or things are continuing to be bad, then I think they do need a referral where we need to investigate for other diagnoses. As in children, more common causes are upper airway problems, where it could be a kind of enlarged tonsils and adenoids, which is causing the problem. It could be some kind of immune deficiency, selective immune deficiency, leading on to recurrent lower respiratory tract infections. CF always used to be on the list, but I'm hoping that with the kind of the screening at birth, we are not missing children with CF. Gastroesophageal reflux, again, is to be considered when symptoms are not being controlled. and other kind of very rare conditions which can lead on to bronchiectasis needs to be considered. Next slide, please. So I've just kind of said these are the things that NICE and the current ERS are suggesting. From their perspective, they have kind of saying that we should not be making a diagnosis of asthma without doing these tests. But I still believe that in children, it is a clinical diagnosis. And most of them, if given the appropriate inhaler and if they're adhering to treatment, then we can achieve control. There's a small percentage who go on to have symptoms despite management. Next slide, please. Sorry, I think you skipped the slide. I think I've made I think the next one and the next one, please. Yeah. So again, so I've just kind of given you some kind of thing. This is for a child who presents with a wheezy episode. So where you've not made a diagnosis. We've not made a diagnosis, and so I think it just tells you what you can tell the parents, written instruction, and what they should do when they should seek medical advice. I know it's not projecting well, but I'm sure you can probably see it in the slides. And these are kind of website where you can download them from the asthma.org.uk. Next slide, please. Again, this is a kind of a thing about My Asthma Plan, where you can give it to the older children who you've made a diagnosis. And I think this is perhaps the most important aspect of pediatric asthma management, where it is not them, but the parents who are responsible for kind of ensuring the treatment is adhered to. So next slide, please. I think the next few slides are just, and this is the asthma test score, where you can ask, this is an objective way of kind of ensuring that you have achieved asthma control, and the scoring which tell you as to whether the control is good or not. Next slide, please. So I think I'm focusing a little bit on adherence, where I think there are different kind of concepts or people beliefs where because of which the adherence can be poor. So I think definitely parents have a lot of concern when we initiate steroids. They have concerns about the children's growth, and they often, you kind of say, even though you have kind of explained to them the rationale of using the things, when they come back for another clinic appointment, they're often not giving it because the child is well in between. And I think that is the challenge in children, that they can have long periods of being well. And so parents often stop the inhaled steroids. And when they have an exacerbation, they initiate it, which is not useful, because the inhaled steroids does not work if you start them at the point of exacerbation. So next slide, please. I know I'm running out of time. So I like this slide. So I think it just tells you that there is often an over-reliance of short-acting bronchodilator. I'm sure it happens in adults and in adolescents, basically. So they feel that it's the short-acting bronchodilator that helps them because it works immediately. They perceive an immediate benefit, or they feel good after they've used it. It helps with their symptoms. Whereas so they feel again, it's not harmful because it doesn't contain a steroid. And underuse of ICS, again, it's the parents often thinking that the steroids have a long-term impact on their growth. There is also an underuse of short-acting bronchodilator by the parents, even though we have, there are instructions that they can use up to 10 puffs in one go for Ventolin, but they often will give 2 puffs every hour because they feel that it's kind of dangerous to give them too much of bronchodilator. It's about managing the beliefs of parents and trying to educate them in the appropriate use of the bronchodilators and ensuring adherence to treatment. Next slide, please. So following the National Inquiry of Asthma Deaths, I think adherence surveillance is very difficult. I know there are sometimes you can have inhalers which you can monitor how much of dose they're taking, but it is not readily available. So I think they're kind of suggesting that an electronic surveillance of prescribing in primary care should be introduced as a matter of urgency, which is easier said than done. But I think it's the transformation of information between primary and secondary care and I think it's trying to improve that kind of pathway to ensure that children are taking, so that we in the secondary care know how many prescriptions they've taken. Either there's if they're not kind of requesting repeat prescriptions, or they've requested too many bronchodilator. So I think that's important, I think, on both ways. Next slide, please. So I think one of the things they've said from a referral from a primary to secondary care, I think they are suggesting that if a child has attended primary care or ED and has received more than 2 courses of oral steroids in 12 months, which is it's not that much, that you should be referring to secondary care. And I have seen quite a lot of children who've come in to referred in after they've had about 3 or more courses in 6 months period. So I think that's what they're suggesting. Or there's more than 2 or more attendants to the ED, or if they've had 1 hospital stay. And the other criteria, if, as in a primary care, if you think that you have prescribed more than 6 salbutamol inhalers in 12 months. Next slide, please. I would just like to finish that in Finland, the asthma incidence is very low, and they've managed to kind of control that asthma in children and asthma deaths quite well. And so this is a study, I think, by Hatela et al. In 2006, where they instituted a national network of asthma responsible professionals, and they trained a lot of nurses, GPs, and pharmacists to act as local asthma champions to help compile data on the condition. So I think, given the fact that UK has got the worst rate of asthma deaths, especially in children, I think we should be looking at ways of trying to improve that. A lot of children can be managed in the primary care, and I think it's more about education, more about ensuring that they're using the appropriate inhaler, and trying to kind of reassure them about their beliefs and perceptions about the inhalers. Thank you very much.
Thank you very, very much for sharing the uncertainty and the challenges in the diagnosis and management of asthma, and really making it a real world or real East Sussex experience of what's really happening. Back everyone, I hope you've managed to stretch and refresh yourselves ready for the next part of the meeting. You may notice in the chat that Sarah Crouch has put a message that for those who can't get online to ask questions, that if you email them to her, you won't be ignored. And we may even try and add them to the chat so everyone else can see your question. I'm now going to hand over to Dr. Wayemi Pereira, who's a consultant in respiratory medicine at Eastbourne District General Hospital. She's also a champion of integrated care services and working to develop them for us and make primary care able to cope better with respiratory problems. So, Dr. Pereira, I think you're talking about COPD. Thank you very much.
Yes, thank you for that introduction. No pressure here. I would say you do the same in terms of trying to improve the care with Sarah, Gemma, and the whole team. So we are a team approach. COPD Back to Basics was the title I was given. Next slide, please. And I thought when I saw this slide from the Gold 2021 guidelines about the management of COPD, I thought this is the talk I'm being asked to give, because we've all been through a really difficult year, and it's not finished yet, because the reset you are going through in primary care, and we are facing it too. And there are a lot of things we can't do the way we used to do. However, I want to remind you that you have huge skills, your clinical judgment and your clinical assessment of patients. So this slide shows that, you know, for COPD, we need to get an accurate diagnosis. And it is first by getting the symptoms that the patients experience, integrating that with their risk factors, and then doing spirometry. I know you're not doing spirometry at the moment in primary care, but I want to give you some ideas how we can still make a probable diagnosis. And when you have a high probability diagnosis of COPD, there are things you can do in your interaction with the patient. So I want to talk about 3 patients I actually met in the first week of June, who I thought illustrate what we can still do for our patients, whether it's in primary care like you are, or whether it's where I am. So next slide, please. So I met Elizabeth. She's an 83-year-old lady who literally looks 65. She used to smoke. She stopped many years ago. She can't even remember when. But I saw in the notes somewhere she had 20 pack years. She's the main carer for her husband who has COPD, and she only takes some Ramipril for hypertension. And she's not someone who troubles you in the surgery. And so the first time she called because she had been breathless for about 6 weeks, and it's been gradual. And the person who spoke to her checked that she wasn't having any peripheral edema, palpitations, orthopnea, or cough or fevers. And I think the first appointment was a telephone appointment, and thought, well, maybe the smoking, she did have a bit of underlying COPD, and she was given some salbutamol and advised to contact again if she wasn't better. She contacted again, and that time thought maybe she's having an exacerbation, and she was given a course of antibiotics and steroids. She contacted for the 3rd time, and this time actually the GP decided to see her face to face, because this was unusual. Elizabeth is not someone who contacts the surgery that often, and this was the 3rd time she was calling in 3 months. So they decided to see her, and when they saw her, she had a quiet chest, and she was breathless just walking from the waiting room, which is not her either. So the GP examined her and actually sent her for an urgent chest x-ray. But because I know it takes you ages, he actually sent her to A&E so that she could have a chest x-ray. Next slide, please. And this was her chest x-ray. And as you can all see on the right-hand side, her lung has collapsed and she had an effusion. So she had been breathless because she had developed this pneumothorax. Next slide, please. The learning for me from Elizabeth was that, this was a study done from data from the primary care database. And if you look at the graphs A, B, and C, on the x-axis you have the years before the diagnosis of COPD, and graph A, years before your patient is diagnosed with COPD, they would have attended with respiratory symptoms, be it breathlessness, be it winter bronchitis. You would have sent them for chest x-rays and things like that. So COPD does not develop over 6 weeks. It develops over months, or rather years. And that's the illustration from this study by Jones. Next slide, please. The other thing also is that patients usually are breathless and have reduced levels of physical activity many years before their diagnosis. And this study was interesting in showing that even patients who who've been diagnosed with COPD, when you do their MRC, or here modified MRC dyspnea score, you can see those who rate themselves as MMRC 0 still have reduced physical activity. So people modify the way they behave well before you make the diagnosis. They avoid the steep inclines, they avoid climbing the stairs. The reduction in physical activity is quite marked. Next slide, please. So This slide, I've shown it many times. When you have someone who has risk factors like this, they smoke or have smoked cigarettes or cannabis, they would have been breathless for years. They may have consulted you previously because of cough, sputum production, or winter infections. They may have a family member with a COPD. Anyone who's over the age of 35 or so who has that, they may have COPD. Next slide, please. And the way to make the formal diagnosis is spirometry and a post-bronchodilator spirometry. And I'm going to skip through this because I know that is one of the difficulties you're facing, and we would be interested in hearing your thoughts about how we can resume this service in primary care. Next slide, please. Then I also want to say, even if you haven't got the confirmed, you can, with discussions, start empirical treatment and code them as probable COPD. But there are other things you can do, and this is from the NICE COPD guidance, is that do the non-drug things. If there are smoker, recommend smoking cessation, refer to smoking cessation services, ensure they have their vaccinations, pulmonary rehab if they have an MRC3 or more. I know without the spirometry that may be a difficulty, but the other thing as well is COPD patients often have multiple comorbidities. You need to assess and treat them as well, because till you've optimized them, they're not going to improve. Next slide, please. For smoking cessation, I really like this definition: to consider smoking dependency as a relapsing, remitting long-term condition that starts in childhood. And every opportunity when you see these patients, even the severe COPDs, who encouraging and reminding them that they're more likely to give up if they use an aid, whether it is nicotine replacement therapy or group therapy. So every time encourage them. Next slide, please. Pulmonary rehabilitation, it has a lot of benefits, and it is one of the evidence-based, cost-effective treatments. Here are some of the benefits, and I know Janie will talk to you more about it. And just remember the patients you have sent to rehab and what they tell you afterwards. It is a really good treatment. Next slide, please. When we approach us patients with COPD, we really need an integrated approach, and the integration is at several levels, not just primary care, secondary care, but also between the difficult aspects the patient is facing, because as I said earlier, they have had the symptoms for a long time and they've modified their behavior even before they think of consulting you, and they have other comorbidities that may also affect. The COPD affects the lung, but it is also associated with the increased systemic inflammation. We know they may have associated cardiac diseases. Even in mild COPD, there's a degree of skeletal muscle dysfunction. And also the fact that these symptoms have been present for a long time has a huge impact on the patient's behavior and social interactions. And that often leads to anxiety, depression, guilt, a lot of things like that. So we need a holistic approach. Next slide, please. Drug therapy. I would really recommend you look at the Primary Care Respiratory Society's paper called Not Everything That Glitters is Gold or Nice, that they published in 2019. And this slide summarizes it with regards to what medications to give and to remember what is the predominant symptom you're trying to treat. Is it breathlessness? Is it breathlessness and exacerbations? Or so I would really recommend you go through this. We have discussed it at previous sessions. Next slide, please. So that was about diagnosis. The next lady is Audrey. She's a patient I've known for at least 5 years. Audrey has severe COPD. She smoked a lot, gave up when her COPD was diagnosed, and she also has bronchiectasis. She has atrial fibrillation, and her average weight is about 45 kilos. She had a previous TIA, and you can see the medication she is on. And when I got a letter from her GP because she had been having antibiotics and steroids every 6 weeks in the last 12 months. She'd been shielding, and she hadn't been admitted to hospital. So the GP was asking, could you see her, because I'm a bit concerned giving antibiotics so often. So what did I do when I saw her? She'd lost weight. She was 38 kilos. When I had seen her in January 2020, she was about 43 kilos, and she was down to 38. And going through her history, what was remarkable is that she was producing a lot of sputum, and I couldn't see any sputum samples on her on eSearcher that she'd had since actually 2019. And she had bloods, which didn't show anything specific explaining why she was like this. And she was also saying, well, can I have some more steroids, because they do really boost me up. She was taking nutritional supplements. So what I did is I sent sputum. Next slide, please. Because coming to comorbidities, we need to remember that COPD patients will have respiratory comorbidities, but they also have systemic comorbidities. The respiratory comorbidities I'm thinking of are asthma, bronchiectasis, like Audrey, and also pulmonary hypertension if they are overweight. And sleep apnea is also a thing to consider if they are overweight. And when there's weight loss, I always worry, and I'm sure you do as well, about lung cancer. COPD patients have increased inflammation, less mobile, they may have thrombosis. And those who also have had a lot of antibiotics and all, think of non-tuberculous mycobacteria. That's why when you send your sputum samples, or when we send, I really encourage someone who's had a lot of antibiotics, don't send just for MCNS, send MCNS and AFB. We're not looking for Mycobacterium tuberculosis. We are looking for environmental mycobacteria, which can colonize damaged lungs like COPD patients have. And then look at the systemic comorbidities, and the whole host is there, because they need to be also optimized. And frailty is one that COPD patients get regardless of the age. And next slide, please. This month, the Primary Care Respiratory Society have actually published a position statement on frailty and respiratory diseases. And you can see their frailty definition and the pre-frailty definition as well. I know different scores are used, but I find this really good. And I would say, whether it is Audrey or most of my COPD patients, they are pre-frail or frail, and that is not age related. And we need to actually be mindful of that and address that, because their needs are higher. And even, for example, when they go to rehab. So that was just to remind you and to give you something new that I saw published recently. It's available for free on the PCRS website. Next slide, please. Last patient is another one who actually cheered me up. Terence is 72, and I met him last year when he was admitted to hospital. And as you know, we have been in the last 3 years or so have COPD nurses who see every patient admitted with an exacerbation, do a discharge bundle, and they are really good. They see most patients admitted. And so the first time his treatment had been changed to Seretide and Spiriva. The second admission, because he was still not well, was started on Trelegy. And then when I was asked to see, is not sure what to do. He also had a CT at one of the admission that detected a lung nodule. So when the nurse came and talked to me, I was like, not sure what else I can do. And we went to see the gentleman again. And what struck me when I was seeing him on the ward is that he couldn't stop talking. He was talking all the time. It was really difficult to place any word, if I may say. And he also had a smartphone, and we explored a little bit more about him, because and what he told us is that he lost his wife at the beginning of the pandemic. He didn't know whether it was for COVID or whether it was something else. It was a sudden death. And he was suddenly, at 72, finding himself living alone, had started works on the house that had stopped due to the pandemic, and everything was in the same state. And he was not coping, and we had to do, in terms of the medication, we thought, okay, let's go to Trimbo because he wasn't getting on with Trelegy. Let's change him to an MDI because he liked the salbutamol, how it worked. And we changed him to Trimbo and discharged him, thinking, okay, that would be good. Didn't work. He came back 2 days later, and was in for 24 hours. I'm not even sure what A&E gave him in an infusion. I think he had hydrocortisone or something, and then rapidly was better and went home. But what we also did at the last thing is we suggested he tries to walk a bit more, and we set really small challenges. And because he had a smartphone and he was very switched on and looking at things, we asked him to look at his step count at home. And he did say to us that his step count on an average day was about 200. So we suggested that he tries to increase it by 10% every month or so. So when I saw him in June, he actually came to our patients, and it was nice to see. He was very proud to show me. So I met him, I think it was the beginning of this year, where he had 200 step count. Now he's at 1,000. He's feeling better, and he seemed like a different man. So next slide, please. What I want to remind you is that breathlessness can be really disabling, and the degree of breathlessness is not directly linked to the severity of the COPD. This slide shows that, you could have patients who have mild COPD, and some of them would have an MRC dyspnea score of 3 to 4 or even 5. And then on the other end, the very severe COPD patients, so with an FEV1 less than 30%, there's a small proportion who may not feel too breathless. So the FEV1 doesn't relate to what their physical activity levels are or their breathlessness. And this was from the GP database, where from your cough, you enter the MRC dyspnea scores. That's where this data comes from. So it's UK data. Next slide, please. This graph is complicated, but it's just to say dyspnea, we are learning more and more about the perception of dyspnea and all. And with new studies of neuroimaging and things like that, we know that there are a lot of communications between the lungs, the different stretch receptors and things like that, and the messages going up to the brain. And these messages are then in our limbic system also intervenes, where our emotions are, before the efferent system enters into action. So our perception of dyspnea is very much related to our emotional state, and that's what this graph I was trying to illustrate. Next slide, please. If there's one article you want to read after this session, I really encourage you to read about the breathing, thinking, functioning model developed by the Cambridge Breathlessness Clinic and published by Anna Spatis. Steve, Sarah and I had the privilege to hear her talk about it. Is the fact that when you're breathless, whatever the cause, there's all the thinking that goes on in your head and the fears that appear, and that conditions your breathlessness and also how you function. And all of us as healthcare professionals, we need to somehow try to empower the patients to break the cycle. And if you read this paper, you will have some tips that you can use. And if you want to spend a little bit more time, Gemma will put in the chat, there is a website about breathlessness from the Cambridge team, and our hospice or the RESP team do a lot of this as well. So I really encourage you to think about, read about this breathing, thinking, functioning model. Next slide, please. For our COPD patients, one of the other things that you all experience and we all see is that it's not one visit fix all. It's a journey, and the journey at different stages, they need different things, and sometimes you need to remind them what happened at the last time. You know, at diagnosis, what patients say, they want to know what it is, what is going to happen to them. We need to do the education. We need to also give some quick action plans that they can use, for example, at exacerbation. And then at your reviews, it's empowering them to self-manage and referring them early to pulmonary rehabilitation, because that, as Jenny is going to tell you, has huge benefits. And the integrated care, where you're looking at the whole of the person in a holistic way, is really fundamental. Next slide, please. And to finish, I just want to show you the COPD patient charter that was published this year. This is a collaboration between different patient organizations, the American Patients Organization, British Lung Foundation, patient representative, and other countries' patient representative, and COPD specialist doctors and nurses. And this is what the patients expect us, all of us who care for COPD patients. I will let you read through this. And I think there are quite a few of these things that you deliver very well. And despite the challenges, we can still do. So I think I'm going to stop here because I've already gone over my time, and I look forward to your questions in the chat or at the debrief. Thank you very much.
Thank you very, very much for a very clear presentation, refreshing our memory, hopefully, on a lot of the concepts that we've been talking about for the last 5 or so years, also giving us some new ideas and how we can use those despite the current COVID situation. I'm now going to hand over to Janie Burgess, who is one of the lead of the RESPS team, and she's going to remind us about the services that are available now. Thanks, Janie.
Thank you, Stephen. And yes, as Wayomi said, there's going to be several links between our presentations, I think. So yeah, my name's Janie. I'm one of the respiratory nurses. I've been around for 17 years, but the RESPS team has been developed and changed during that time. You can see all our lovely smiling faces there. That was done because we were finalists for the Nursing Times Awards last year, so we're very proud of that. Multidisciplinary team, so we have nurses, physios, support workers and administrators, and we all play our role in covering not all of the county now, but most of what used to be Eastbourne, Hailsham, Seaford area and Hastings and Rother area. Next slide, please, for several services. So we have the lungs in the middle there, and around the outside there's a lot of information, but obviously you'll get it all in the presentation. If we start bottom left, we do a COPD discharge bundle in hospital. I'm going to tell you about these services in a moment. Admission avoidance is for outpatients. Physiotherapy, breathlessness management, as Wayomi was saying, and chest clearance. Oxygen assessment and review. pulmonary rehabilitation, chronic disease management, and early supported discharge. So I also wanted to say it's Pulmonary Rehabilitation Awareness Week this week. So I hope you're all thinking of that while you refer your patients. We'll be tweeting a few things on Twitter, and our name is at ESHT, ESHT_RESPS. Next slide, please. I should have put that on our contact details as well. Nowadays, I think we all have to be on social media. So there's our telephone number. We do have someone monitoring and replying to calls between 8 and 6 during the week, and 9 to 5 weekends and bank holidays. We have a duty clinician every day. We're not actually in the physical office next to that phone, so we check messages, and it's usually a voicemail, but we will get back to you. Next slide, please. So on here, I know you can't read all the details, but I'm sure most, if not all of you are aware of our 2 referral forms. The one on the left is the general form, that's for pulmonary rehabilitation, chest physio, breathlessness management, chronic disease management, people having frequent exacerbations. So the one on the right is for oxygen referrals. For both, we need medical history, medication, and if the patient has COPD, we need spirometry. Our patients that we accept for have either COPD, bronchiectasis, or interstitial lung disease, as you can see at the bottom of the slide in green, or possibly all 3, as happens very rarely with patients. Asthma is absent, as you can see. A lot of our patients have that as a comorbidity, but unfortunately we can't accept for asthma alone. The oxygen patients are slightly different, as you can see at the bottom in blue, as they may also have heart failure, pulmonary hypertension and cluster headaches as part of the home oxygen service and for assessment and review, the HOSAR. These patients that we can accept, unfortunately we can't accept for palliative or urgent, but we can give advice to clinicians. Next slide, please. So I'm going to start with oxygen, because that is quite a big factor. Does the patient need oxygen? And that's the best place to start. So I've given a little clip of the information that we have on the hospital extranet. I'm quite happy to send it on if anybody wants it. It's just a document that guides you through how to assess what forms you need, where you send them to, and how to refer to us. So as you can see on the left-hand side, does the patient have a confirmed long-term respiratory or cardiac condition? And if it's the red box for no, then you explore what diagnosis they may have. If it's yes, then you carry on with the checklist. Is their treatment optimised? And you might refer to the NICE guidelines for whatever diagnosis. If it's not, then we consider you optimise their treatment, because that may resolve the hypoxia. If yes, you continue. Do they have peripheral oxygen saturations of equal to or less than 92% after a minimum of 20 minutes on air, if they've been using oxygen? If not, if it's above 92%, then continue optimising their current treatment and review again. You can review these refer these patients to RESPS. If it's yes, continue with the checklist. And you can see bottom right, there's one of the technicians from Dolby Vivasol, the oxygen supplier, just delivering some portable cylinders there to someone who's waiting very keenly in the doorway. Next slide, please. So oxygen equipment, this is just a selection of what's available, and part of the reason that oxygen assessment and prescription is so complex. On the left hand side we have some of the concentrators. The one with the little extra box on the top is a self-fill concentrator, so you have little portable cylinders that they can fill up themselves, so they don't actually have to have a delivery every week, which is better for the patient because they can use as much as they like, and it's better for the NHS finance pot because there's no extra cost in delivery from Dolby. In the middle at the top there's a blue carry bag with a portable cylinder. These still weigh about 3.5 kilograms, so they're empty. There's still quite a weight for patients to carry. At the bottom is a portable concentrator with the handle. There are slightly smaller ones around now. The one with the brown desk around the shot is a conserving device, which does what it says in the name. You connect it to a portable cylinder, and because we don't need the oxygen to be delivering continuously, only when we breathe in, has little sensors in the nasal cannula. As the patient breathes in, you hear a little ch, and the oxygen is triggered. So that's really useful to limit their supply when they're not needing it. And top right, we have the liquid oxygen flasks. Heliox is often written on there. So they're great because you need a lesser volume, so they're smaller, but equally you can't fill them up and leave them like you can with the other portable cylinders because liquid oxygen evaporates. Bottom right is, this is not in proportion, all of these, it's much bigger than it looks. It weighs as much as a person, and can only be delivered to ground floor areas because of the size of it, but also because liquid oxygen has to be stored very carefully, so they will do a risk assessment. It can't be anywhere on a first floor in case there's a spillage when they're refilling their flasks and it seeps through the floor to whoever lives below and the person doesn't realise and is smoking. Next slide, please. So the big one for this week, pulmonary rehabilitation. And I would say this is probably the vast majority of our referrals that we receive from primary care. This is an evidence-based, as William has given you some information, exercise and education programme, both equally important to reduce breathlessness and other symptoms, all about quality of life, improve self-management and reduce healthcare costs in reduced admissions or primary care attendances if they're managing their disease well. It does require a certain commitment from the patient, and they need to be aware of that. They have an initial assessment with us to triage. They then have a pre-assessment, 2 sessions a week for 6 weeks, and then a post-assessment. So 14 attendances just for the pulmonary rehab. There is a long waiting list due to the pandemic, I'm really sad to report. But positively, we are one of the few teams to recommence the proper face-to-face programmes, but at a reduced capacity. Sorry, I forgot to include the slide, and my colleagues will be very cross because they took lovely photos of what our stations look like for patients. But we have a maximum of 10 patients per group in a large room. They have their own station with a chair, their TheraBand and all the equipment and documentation that they need to stay in that space. Because of the waiting list, we need to make sure that all referrals are appropriate, and I'll go through the inclusion and exclusion in a moment. We are still providing the remote pulmonary rehab, where patients view and do their exercises at home with weekly contact from us to support them, make sure they understand the education, the exercises, triage any problems that they're having. And obviously we adhere in the face-to-face contact to national guidance for the social distancing, and they don't share equipment anymore as they used to. Next slide, please. So this is the exclusion-inclusion criteria. On the left, any patients who have cancer with a poor prognosis, ongoing treatment or investigations. This isn't because we want to exclude them, but they often have so much going on anyway. They may be very symptomatic. They have a lot of appointments. And for them, it is quite a commitment to have to come to pulmonary rehab as well. If people are stable, that's no problem. We're more than happy to assess them. Unstable medical conditions, blood pressure, high blood pressure in particular is the biggest one for this, over 160/90, arrhythmia, angina, myocardial infarction or pneumothorax in the past 3 months, obviously not an exhaustive list. Uncontrolled diabetes, cognitive issues we can potentially get round if they have a carer or someone who comes with them to guide them, support them and remind them about their exercises when they're at home, because this isn't just for the 14 attendances, this is for life that we hope they carry on with these exercises. If they have any impairment or condition made worse with exercise, and it says underneath restricted mobility, then we talk to our physios. Usually we can get around things. If they have a particularly bad knee, they're waiting for a replacement or something, we might be able to exclude certain exercises. A BMI of less than 18.5 or abdominal aortic aneurysm of greater than or equal to 5.5 centimetres. More positively, the inclusion. Anyone with COPD, bronchiectasis or interstitial lung disease, MRC dyspnea grade 3, 4 or 5, potentially a 2 if they have some times where they're symptomatic of a 3, significantly symptomatic. No contraindications, obviously. The breathlessness from pulmonary origin, they need to be mobile and able to exercise. Treatment's already optimised. and they know it's a group activity, unless they're doing the remote class, with the attendances that I've talked about. Transport to venue. Fortunately and unfortunately, we don't regard this as a treatment that we are doing to patients. It's something that we want them to engage in for life. It's going to be part of their life now. So it's not held at hospitals. We don't have any space there. So that means, unfortunately, we can't get hospital transport. And they need to be motivated and want to come along. Next slide, please. I won't read all of these out. These are the sessions of education that we provide at pulmonary rehab. I think the only one that may vary is the smoking cessation. If we know that nobody attending smokes anymore, there's not much point in us doing that, but we do always have information. Next slide, please. So we come on to what we do in hospital now. So vast majority of our work is out in the community now. We are technically an integrated team because we work in hospital and in the community, in people's homes, community clinics, health centres, community centres, village halls, church halls, all over the place. But the COPD discharge bundle is primarily an education programme and a review programme that we have 2 dedicated nurses at Eastbourne, DGH and Conquest who spend a lot of time going around the wards, talking to staff, finding out which patients have been admitted with exacerbations of COPD. So we're actively recruiting these patients, which is time consuming but effective. And for GPs, practice nurses, anybody working in primary care, you will receive a copy of the front sheet of the form, which may not make an awful lot of sense when you first glance at it, but it means we've assessed these people and we usually give suggestions if we think there's any changes. So on the grid, you can see there we do COPD education. The only reason it might be inappropriate is if the patient does have quite advanced dementia or some reason that we couldn't do it effectively. In that case, we consider if they've got a carer we can talk to, give written information, find a way around it, or give them some information. Smoking cessation, if they're still smoking. Inhaler technique, not just the device they're doing, but also the inhaler regime, if it's appropriate or not, and we might suggest changes. Pulmonary rehab, we talk to the patient about that and do an internal referral. We don't ask anybody else to refer on our behalf. Oxygen alert card if they are admitted with type 2 respiratory failure or if they're on oxygen. Self-management plan and a detailed explanation of that. And whether they or not they need a standby pack to keep at home for prednisolone and antibiotics. And we also consider how many admissions and exacerbations they've had and what kind of follow-up they need from RESPS. They all got a telephone call within 2 weeks of discharge, and that's when we're just checking everything's okay. So we may refer on or ask the GP or somebody at that stage if needed. Next slide, please. Admission avoidance. This is for patients known to us. And is almost the opposite of what we're doing in hospital, where we're trying to keep them out and at home. So patients call us generally, leave us a voicemail, and then the duty clinician will telephone them and triage their problems. So on the left, you can see a snippet from the self-management plan, what to do if you have an exacerbation. And we say to patients, an exacerbation or a flare-up is if you have 2 or more symptoms for 2 or more days. So they can have a very brief period of breathlessness. They might talk to us. We talk to them about techniques on the phone. We wouldn't say that's an exacerbation if it's just lasted the morning. We may say to them, OK, try these techniques and we'll call you back tomorrow, or they can call us back tomorrow if they're still symptomatic. So we then give them advice on when to take their prednisolone or antibiotics. And then, as you can see underneath, it says we have a telephone review service for existing patients, and we have 3 dedicated clinics each week, which is generally either myself or my colleague Tessa, who's listening in, who we telephone the patients like a follow-up review. On the right-hand side is the guidance that we can use, which is actually for early supported discharge, but we're using it the other way around to see if it's suitable for them to stay at home or whether we need to consider some kind of other referral to either GP for review or whether they need to be seen in hospital at all. Next slide, please. So breathlessness management and chest clearance is all squished very small onto one slide, I'm afraid. The key bit is the bit in red there that I'm sure you all know. Breathlessness is not the same as oxygen levels, but I would suspect that myself and my colleagues say this to people several times every working day. And we try and explain to them why it's not necessarily the same thing. You can have one without the other. So the terms and the techniques we may use with people is relaxed, slow, deep breathing, pursed lips breathing, blow as you go, which always gives people a bit of a chuckle because they think, what on earth are we talking about? Paced breathing and diaphragmatic breathing. And I would say there's an awful lot of techniques to all of these. If you're not familiar with these terms and if you'd like to learn more, then please contact us and you can come along and attend that hour session at Pulmonary Rehab and see the physio teaching the patients and see a bit of pulmonary rehab if you have time. At the bottom of the slide, we have chest clearance. The a cappella device is bottom left that you may be familiar with if we've asked you to prescribe one. So our physios will assess patients for one of these to help with chest clearance, and we provide the first one and then they have to have the ongoing ones provided in primary care. Bottom right is the active cycle of breathing technique, ACBT, which we teach a lot to patients. Next slide, please. Chronic disease management tends to be encompassed everywhere and is very similar to the COPD discharge bundle. We are educating them about their respiratory condition. We talk about the medication, inhaler technique, adherence, considering the number of admissions to hospital for exacerbation of COPD or bronchiectasis, and number of exacerbations they're having and what happens during their exacerbation, whether it really is a true exacerbation, infective or not, have they had a sputum specimen, and consider if they're suitable for the frequent admissions clinic, which is people who've had 2 or more admissions for exacerbation of COPD in the past 12 months. Consider a self-management plan if they have COPD or bronchiectasis, and we also bear in mind they may also have asthma and an asthma plan, so we talk to them about that. Education on their respiratory condition, I've already said, and consideration for any of our other RESPS services. Next slide, please. Early supported discharge for patients within the Hastings-Rother, Eastbourne, Hailsham, Seaford area with COPD confirmed on spirometry. So we need to have that information to hand. If they fulfil the criteria on the previous slide I used for admission avoidance about being able to go home, this is for patients with it, this is with it all within the NICE guidance, discharge within 3 days of admission, and the consultant retains responsibility of care for 30 days. Ideally, we would visit them at home the next day to review them. And I just wanted to add at the bottom, no appropriate patients. That means that we haven't actually had anybody appropriate recently. They're recruited from the COPD discharge bundle. So we are always bearing in mind, is this person suitable to go home? There hasn't been anybody during the pandemic at all. And we think this is because admissions, when people come in, they have far more complex problems. They probably left it a lot later to be admitted because everybody's trying to avoid being admitted to hospital. Next slide, please. So a side arm of that is the home NIV, non-invasive ventilation service. And my colleague Laura is listening in, but she's not able to speak very well today, connection problems and a physical problem. So I'm sure she'll let me know if there's anything that needs to be added. But it's basically providing home BiPAP, bi-level positive airway pressure. This is within Hastings-Rother, Eastbourne, Hailsham, Seaford areas, and also motor neurone disease patients in Uckfield if they're known to St Wilfrid's Hospice. We're often asked about CPAP. CPAP's continuous positive airway pressure is provided by the Sleep Studies Department in Conquest Hospital that Dr. Christopherson mentioned earlier. At present, we have 1 consultant and 2 specialist nurses, but we have another support worker starting soon. Next slide, please. So who may benefit? Anybody who's had type 2 respiratory failure requiring BiPAP. These patients obviously will be in hospital. Underlying health conditions such as COPD, interstitial lung disease, obesity, hypoventilation syndrome. They may have tried CPAP in the past, scoliosis, motor neurone disease. Not patients with tracheostomy ventilation or complex medical histories which are managed by specialist centres such as the Romeo Lane Fox Unit or Royal Brompton. And next slide, please. And those are the contact details for the home NIV service, and referrals are available on eSearcher. Generally, our referrals are coming from the acute hospitals. At the moment, they're conquest-based, so they can't review patients in Eastbourne DGH necessarily on the same day, but we work very closely together and see joint patients and help each other out a lot. So that was everything from RESPS, and I think we're going to move on to the questions in the panel. Thank you.
Thank you very, very much, Janie. That was very, very informative, and I'm sure helped a lot of people, particularly focusing on oxygen, which we know has been a big issue for people, how to prescribe and the support that's available. You've got lots of claps there. We're going to actually take a 10-minute break so people can stretch and get another drink if they wish. And we'll be back on time at 11:10. So thanks for putting us back on time. See you all in 10 minutes.
Thank you.
Welcome back, everyone. And I hope that I've got everyone who's been presenting on the call now. I wonder if you'd like to show your faces. Thank you, Dr. Pereira. And thank you, everyone, for the questions we've had sent. I'm sorry, I'm a bit lost, Sarah. Do you want to start by asking one of the questions that we've got? You there, Sarah?
Yes, sorry, I'm here. I'll start with the first question, which was to Dr. Christopherson, and it was asking about the waiting time and capacity for sleep studies. I don't know if Dr. Christopherson is on the call. If not, she's just emailed me the response. So at the moment, the wait is for an appointment is 4 to 6 weeks. And then a sleep study fairly quickly afterwards, so probably another 2 to 4 weeks, depending on what kind of study and the clinical urgency. Second question, and perhaps Wayne, if you're able to pitch in, if Dr. Christopherson's not around, is there any particular monitoring we need to be aware of for patients on biologics for us in primary care? So Teresa's replied, IgE is not a specific marker of success for biological treatments. Primary care monitoring should involve peak flow variability, symptom evaluation, inhaler technique assessment, smoking assessment and cessation, peak flow monitoring, diagnosis of comorbidities and treatment, and the referring service can review the pheno for type 2 asthma. Wayne, is there anything you would like to add to that?
No, I think that's quite comprehensive. So I think the fact the patient is on a biologic doesn't mean there's anything extra that should the primary care would have to provide, because usually the biologics are led by a tertiary care centre. So if I identify someone who's suitable, I send them elsewhere. We don't at the moment prescribe the biologics. So it's the usual enhanced asthma review that you need to do.
And I've got a question for Dr. Gopal. It asks, when someone's seeing a child with recurrent wheezing in primary care, at what point should you refer to secondary care? And they're particularly interested if the child has had a good response to inhaled corticosteroids, whether they should still be referring. You're on mute, by the way, Geeta.
Can you hear me now?
Yes, thank you.
Okay, so what I would say is, I think one of my slides did refer to that, is in the preschool age, again, as I said, if what you would be thinking is a suspected asthma or wheeze, and these children often do tend to get better as the younger they are, the more likely that their symptoms will improve. So if you've had a good response to ICS and you're happy that there is no other alternative diagnosis and they're not receiving too many courses of steroids, then the main thing is to monitor. And if if they're symptom free, try and get them off the ICS at some point. And if symptoms don't return, that's fine. So the reason for referral would be if either they're not responding or despite being on ICS, they've had, as I said, needing steroids at least 2 courses in 12 months, then yes, we would like to see them. Or if you're suspecting that this is not asthma and there's an alternative diagnosis, then yes, would be an answer.
Thank you. And someone else was asking about when you might use oral steroids in the absence of a clear diagnosis of asthma, in the under 5s, whether you'll be happy for us to use oral steroids.
So again, I think this again goes back to the labeling of suspected asthma. If you have a child who's wheezy and you feel that there is a response to bronchodilator, and that can be only a clinical assessment, and if there's supporting evidence that there is the probability of asthma is high, then it's okay to give them a short course of steroids. However, as I've said, if this is happening recurrently, then I think that needs to be referred in. So it's okay to give, because I think, as we said, the management is addressing the inflammation and relieving the bronchoconstriction. So, but I think it's about looking at what you think is the probability of this being a suspected asthma, or if there's a good response to bronchodilators. It's difficult in children, but that's what I would suggest.
We've also got a question which has actually got a personal part to it, but the most important part of the question is, how far have we got with having clear guidelines for the management of patients with asthma when they present to the emergency department at the hospitals?
They have got, we have got kind of guidelines which is on our drive, shared drive, and A&E have access to it. I have seen the question, but I think it's more important because, yes, about the severity, they may be able to pick up the severity, but it's about knowing each patient and what their kind of severity is. And I guess that's where there is the importance of the self-management plans and some kind of thing to allude as to how severe they are. So often if we find somebody is a brittle asthmatic, then we often put them on our open access things, and A&E should have an access to the severity of it. I know sometimes the technology doesn't work, but yes, I think it's not.
Certainly the NRAD report that you talked about actually has looked at asthma, hasn't it? And looked at the management of adults and children and the response times in the emergency department with such basic things as time to first use of an inhaled short-acting beta agonist or doing a peak flow or basic measurements. Are there any plans for adults and children that we get on the improve the protocols?
I think we have found in our A&E there's either over management or under management. So we have had, at least at the Conquest side, we have had quite a lot of small group teaching sessions, and we are continuing to do so to increase the education because the trainees change, so that's happening. But there's always room for improvement, and hopefully we will get there one day. But
I will also add the same as Geeta. So I would say we are liaising with the A&E teams, and they invite us now to do an induction because, remember the A&E juniors change every 4 months. So we are trying to give them some basics in terms of asthma management, COPD management. I'm talking about for adults. The second thing we are working on, and Shankas and Dr. Ravi Reddy, the respiratory clinical lead, are leading on, is to try to have hospital asthma specialist nurses, so that any patient who's adult patient admitted with asthma is seen like the COPD patients are seen for the asthma discharge bundle. Shankar's working on a business case, because the NACAP audit actually is asking us to do that if you think of an admission to hospital with an exacerbation, it's like I don't know, you can compare to a heart attack. People who come in, they get the full package. Why is an asthma exacerbation any worse, considering that it affects working young people, and it has a huge burden, both the societal, because of lack of absence from work, etc. So yeah, we are trying to get hospital nurses that would support with that. That's what I would say. Thank you.
Sorry, Karen, can I just add, I think in keeping in line with what Vaimi has said, we are also looking at kind of having asthma nurses both for the outpatients, and we have some A&P pediatric nurse practitioners, and we are trying to enhance the skills of them, so that, again, as per the audit, it is recommended that if somebody is discharged, before they're discharged, somebody with an expertise in asthma sees them and goes through the training and education. So hopefully that could be extended on. They could go to the A&Es and support the children when they come in. So that's being looked at.
Sarah, how are we doing for the questions? I can see one on spirometry. Are there any other questions that have come in that we haven't answered?
You may be on mute, Sarah.
Well, sorry. Obviously, what I was saying was very interesting and important. But so Waimi, you've already answered on the chat the question about chest X-ray and FBC and whether it's required 3 yearly for COPD patients, and confirmed it's not recommended by NICE. Janie, there's a few questions that have come through from your presentation. One is the current waiting time for pulmonary rehab. And Shankar, you've already responded in the chat that there's 299 on the waiting list, but we've currently got 5 programs running, and we're doing the preparation for a CFID program as well. And then there was a query around RESPS exclusions for low BMI, and obviously they can absolutely be referred to to RESPS, but they won't be able to partake in the pulmonary rehab program. Is there anything else you want to add, Janie or Shankar, around that?
No, I think that's covered it really. But yeah, any patients with COPD, ILD or bronchiectasis can be referred to us, and even if they're not suitable for PR, we always assess if there's anything else we can do. Talk to them about their condition, education, checking things.
So yeah, so there's a few people have come up with spirometry. There's one more question before we go to the spirometry question, which is what is the maximum PRN dose per day for ICS and the formoterol QDS?
I think if I try to respond, I'll say what I tell to my patients when I give them that is if you take too many, they will get palpitation and shakes. So I think one of the things I've observed with people who are using one inhaler maintenance and reliever is first to inform them and educate them that even when they're well, they need to take at least 1 dose, if not either if it is a BD thing, 1 puff twice a day, they need something. PRN, it's not just PRN, so they have a maintenance dose, and if they are on top of their maintenance, they are symptomatic, they can take extra puffs. And I usually say 8 puffs is the maximum a day. But be aware, the more you take, the more you're at risk of getting palpitations and shakes. And also, if you're needing more than that, something is not right. You need to speak to a healthcare professional and get checked. I can't evidence-based it, or it's more a pragmatic approach and kind of the safety thing I tell my patients. That's my reply to that person, to Alexandra.
Dr. Christopherson, do come in.
Hello, sorry, I couldn't get back into the meeting. So yes, I agree with Dr. Pereira. Formoterol is very quick acting, so that's why it's the GINA recommended combination with ICS. I think if the patient isn't feeling an improvement, it means there's something wrong, and either their technique isn't very good with the inhaler, or they've got another problem. And then often these patients have other conditions, and it's not actually the asthma that's giving them the symptoms. So there might be some sleep apnea, obesity going on, other conditions. So yeah, I agree totally, Dr. Pereira. It's a combination inhaler with formoterol because it's quick acting, and they shouldn't need more than 1 puff because it's so effective. If they're not getting any benefit, it means something's wrong. Either the device isn't giving it correctly, or there's another problem going on.
Before we deal with spirometry starting it, we've got questions about referrals being rejected by RESPS due to spirometry. One of them says it's a progressive disease, so if we've got abnormal spirometry, why do we need a new one? And the other one's saying lots of referrals declined. I don't know if you'd like to talk about that, Janie.
Yeah, I'm quite happy to mention that one. We don't mind how old the spirometry is, as long as there is spirometry that confirms the COPD. That's what we're looking for, because it does say on the referral form we're not a diagnostic service, so we can't enter into the kind of whole process of exploring if it is COPD or something else. We just don't have the ability for that. But if there is confirmed spirometry that confirms the COPD, we're happy to accept referrals. If they're being declined by HSCC and not passed on to us, obviously we're not aware of those ones, but usually HSCC will pass them all on to us. So if there are problems and you feel that they are, the spirometry is confirming the COPD and you're still getting a problem, then please email the RESPS email address and we'll try and sort that out. We're not asking for new spirometry. We realise that's not possible.
Lovely. Shall we, so that everyone's involved, we thought it'd be nice to have a question now, really inquiring about how people in primary care feel about spirometry. So we're going to hopefully launch a question now. Jenna, over to you.
Yes, so if you could just answer the poll, that would be really helpful as a starting point, and then we can talk about the plans to date that are starting with Sussex ICS.
Hopefully you can see the results coming through in the chat, Stephen.
I can. We've got 37 votes in. I'm not sure if we're going to get many more. It's not going up so quickly now. Well, it's 39. So give them another 20 seconds and then perhaps we could launch the second question. Lovely. Do launch the second question. So the answers that you give to these questions are going to influence how we approach the ICS with regard to how we're going to provide spirometry or what we do to support you. That's really, really helpful. Thank you. Can you see the results, Emmy?
Yes, I can.
Fantastic.
So shall I introduce
the slides?
Sorry, Stephen, shall I introduce the slides
and
talk
useful,
through?
Particularly as the major issue seems to be infection control, which is certainly the thing that, as a group, we've been most worried about. Do bring up the slides.
Thanks, Gemma, if you could put them up. So conversations have started about how we can restart spirometry across the ICS, and currently the ICS respiratory team are drafting a framework to support primary care for restarting spirometry. So we thought it'd be really helpful to set out what the current plans are, and to get some initial feedback from yourselves whether you think this would be helpful. So obviously, as we all know, spirometry is a major issue, and we would like to move towards restarting spirometry in primary care for diagnostic purposes. Many practices are keen to provide it, and secondary care just simply don't have the capacity to support. And there has been further recent guidance published by the PCRS, BTS and ARTP, which has formed the basis for the draft framework that's being developed. So Gemma, next slide, please. So there's the risk mitigations that are currently being proposed are that the room should be clean and free of unnecessary items and medical equipment. The room must be well ventilated, and what we mean by that is obviously open windows where possible, and leave the room ideally for an hour between patients. Obviously, if you've got mechanical ventilation, you may be able to reduce that time. A single-use antibacterial antiviral filter should be used for all testing. The spirometer should be cleaned by the using manufacturers and national COVID-19 cleaning and disinfection instructions, and then anything the patient may have come into contact with during spirometry should be cleaned after each test. In terms of PPE, spirometry obviously isn't an aerosol generating procedure, so it should consist of the standard and droplet transmission precautions. So that's disposable gloves, plastic apron, visor, and a type IR surgical mask. And if it is available, but it's not essential, you could use a perspex screen between the patient and operator, and then obviously use the hand hygiene. Next slide, please. So on the day of testing, obviously review the standard COVID-19 screening questions, and then if there's any concerns, postpone spirometry, do a temperature check, undertake a COVID-19 lateral flow test, and review the result after 25 to 30 minutes. Counsel the patient on spirometry associated cough. So to reduce the risk of cough, explain that if possible, patients are encouraged to stay on the mouthpiece, and if they do come off the cough, then have in place a surgical mask to place fully over the mouth and nose where possible. So that's kind of a very brief summary. It is intended as a framework. I think really interested to get your views, and we wondered if it would be worth kind of re-looking at the poll to consider if that's helpful or not. Shall we run through a few of the questions, Stephen, that have come up in the chat?
That sounds a really good idea.
And I have to say, we probably don't know all the answers to this, but what we certainly will do today is take any queries away, and and get back to you with the answers. Just what wasn't covered by that is the loss of confidence that some people may be feeling. And in East Sussex, we have been working with the training team, and we are planning a series of spirometry training sessions to support you in going back to restarting spirometry. So let me see some of the questions. Do you have any idea how much extra this will cost us to deliver? Partly rhetorical question, of course. I mean, Stephen, do you want to respond to that? I think the short answer is no, not at this stage.
Yeah, I mean, as I understand it, we can get the viral filters, so they're free. I think the expensive time is the extra time it's going to take to do the spirometry. We're lucky in East Sussex that we've got an enhanced local commission service for the whole of respiratory care, but it doesn't specifically fund spirometry in other areas of the whole of Sussex. We're not just dealing with Brighton now, we're also dealing with the whole of West Sussex. Some areas have no extra funding, and we're trying to work to develop something that will work for the whole of Sussex. So at the moment, there isn't money that's going to come for it. So it would be an act of faith almost by primary care to restart it, although of course we are getting money through the LCS still. But no, I don't. And again, I think it's very difficult, as we put on one of the slides, it's for general practice itself, each individual one to decide what level of precaution they need to take. And it's obviously going to vary according to the rate of COVID in the community. I don't know, Naomi, you want to say anything about spirometry at the moment?
Well, I'm really finding interesting all the comments that are coming in the chat, and it's nice to see the challenges you are facing. We face the same in secondary care, in the sense that before we used to do them in our clinics, and now we can't do them, and we've had to adapt. I would like to put back to you, what about, you've got PCNs, what about having a hub in each PCN? Because someone has put the idea of getting an external provider. I would wonder whether you want to consider PCN-led diagnostic hubs, which will encompass spirometry and exhaled nitric oxide, because that would improve your management of both asthma and COPD. And Stephen and Hader helped. We did apply to try to get something, and we're waiting to hear about a diagnostic hub. And the room space, that would always be there. So I think at PCN level at least, maybe not at surgery level, that needs to be addressed, because if you look at the overall drug cost due to either wrong diagnosis or inappropriate prescriptions, that is costing everybody much more, and therefore we need to make the rooms available. And I can appreciate each surgery can't, but I think the PCN is maybe the way forward. Hader and the other PCN leads, I'll be interested in your thoughts.
I think do go ahead, Hader, sorry.
Yeah, I think everyone knows I'm very supportive of diagnostic hubs, something we're missing in East Sussex. Whether it's for COPD, spiros, or whether pheno-testing for asthma or suspected asthma. We've put our request. I don't think we have heard back from it. We had discussion from 3 PCN so far, I believe. They were supportive to the idea. It's a matter of whether we'll get the right funding for it.
And certainly funding is a big issue at the moment. As far as we're aware, there's absolutely no extra money coming to set up these services. We've applied for some starter funding, but there is no funding. I think that one of the questions I'm interested in is how keen practices are to keep spirometry within their own practices, and how much they would be happier if it was going to the PCN and done at a larger level. I don't know if we can do that question, Gemma, when you're ready.
So just have to set it up, but yeah, we can get that poll out.
And certainly across the rest of Sussex, particularly the Brighton area, the push is that for quality assured spirometry, they would prefer it to be done in more specialist settings. There are advantages and disadvantages to that, but certainly if we feel that's the way we'd like to go, there would be encouragement from the rest of Sussex.
So from the messages in the chat, I'm taking that kind of one of the main issues is obviously around, as well as infection control, is this room space. I will take back to the Sussex ICS the query around the lateral flow and tests, and also I'm just having a look, but I'll collate all the responses and get a response back from the ICS and make sure it informs the framework. The question around whether it's an AGP or not, yes, that's confirmed that in the UK, spirometry isn't considered an AGP.
But when they cough, it can be aerosol generating. And as Dr. Pereira and many specialists will tell us, if you're doing good spirometry, particularly on a patient with significant respiratory disease, they will cough if it's been done properly.
Stephen, can you just repeat your question so Gemma can set up the poll, sorry, and we'll get that set up.
It was really to get a gauge whether people feel that we should be trying to get spirometry back into primary care, or whether it should be done at a hub, which would probably be based on a PCN model. You know, the advantages, you know your patients, you're engaged with them. The disadvantage is the time and the extra requirements for spirometry now. And if you like, the lack of control, if you like to be able to control things more. And the fitting in, because we know you've got to be 6 weeks clear of an exacerbation.
Gemma, are you right? Just put something on.
Someone's written something out very interesting about how about being seconded to the hub on a rotation to keep your skills. Certainly, Hyder and Wham, in my plan would be that we would use the resources of the practices to rotate into the hub. WAME would be very keen to support in a role as an integrated care consultant and develop knowledge and experience that way. So yeah, very much we would be hoping that practice would release staff to do the spirometry and the pheno testing.
Yeah,
hopefully that's popped up. I hope those answers are as planned.
That's great, Jenna. Someone's just asked the question whether there's the option of either. I think practice will always be able to do it within the their own practices. As I say, primary care is a business in itself, so you'll be able to decide what you do, absolutely. But the funding probably wouldn't be there to do it if we set up the hubs. And as I say, we'd be hoping that we'd be able to second and develop the people doing it in practices to be doing it in the hub on some sort of rotation basis. There's a question about ARTP. Certainly, what was meant to happen is from the end of March 2022, we're all meant to be ARTP trained, but as I understand it, that hasn't been finalised. And certainly the hope is that there'll be an appropriate training for primary care for spirometry rather than the full training that's required for the full ARTP qualification. I think we've got our answers to the poll as far as we're going to go. That's really, really helpful. Have we answered all the questions that need to be answered, do you think, at the moment about spirometry and other things?
I think so, but obviously what we'll do is we'll review all the questions in chat, and following this event we'll obviously send out all the presentations and the recording, and probably like an FAQ answering the questions that have come up to make sure we've covered everyone's points.
Mine and Sarah's email addresses will be shown at the end of this. Mine's just stephen.litton@nhs.net. Do send in your emails. We will collate everything. We're going to try and send a newsletter out with answers. So just perhaps I can wrap up with a few final thoughts. I hope you've all found the talks supportive and instructive, as I have. Dr. Christopherson highlighting the developing understanding of the difference between patients and the types of asthma they have and the impact that this has on management, the GINA guidelines, the earlier introduction of treatments and the use of monoclonal antibody therapies. Dr. Kopal, the importance of attaching a diagnosis, even if it's only a suspected diagnosis, and also communicating this diagnosis to patients so their children are appropriately managed. The challenge of concordance with patients and the fact that patients tend to stop their inhaled corticosteroids when well, inappropriately. She's flagged up the use of spacers again, and the dilemma, which I thought she particularly well articulated, about what we're getting from NICE with regard to needing confirmatory tests, which of course firstly aren't available, and secondly from her experience are difficult to administer with children, the phenos and the spirometries, and the fact that asthma really is still a syndrome. I'm quoting her previous talks, and clinical experience and reflection in action are key here. Dr. Pereira set us the challenge of taking COPD management further with an even more holistic view, but also ensuring that checks are put in place not to miss other diagnoses. Thinking about both comorbidities of within the respiratory system and also outside, and optimizing therapy, and then encourages all to look at the breathing, thinking, functioning model of the Cambridge group led by Anaspatis. Finally, we had Jamie Burgess talking about the respiratory service through the RESPS, what's available, what's there to support our patients, a focus on oxygen and the challenge of prescribing oxygen, whether or whether not to, and also what our patients can hope for if they do unfortunately get to the hospital in the way of support from the RESPS team. I also thank you very much for your involvement with the questions, which are very, very helpful and will be acted upon. The whole of Sussex is very interested in the outcome of this meeting and particularly the questions, so very, very grateful. I think you've got a few documents there to look at, and as I say, this is recorded. Can I hand now to you, Sarah, to take over?
Yes. So we've just put a feedback questionnaire in the chat as well, a link to it. So we'd be really grateful for your feedback. Apologies at the beginning for a few technical